Good evening, everybody. Um, Thank you, Dr. Anju, for the introduction. I'd like to thank Dr. Subroto Day for giving me this opportunity. It's a wonderful conference, and we are really enjoying the academic feast. So, moving on to childhood osteoporosis and an approach for evaluation. So, I'm actually going to take you through a few steps before I really go down to the approach, because you need to know a few things. So I'll talk a little bit about the basics of what the DEXA is, what parameters we measure, how you diagnose osteoporosis in children, interpretation of DEXA scans, indications for DEXA scanning including secondary osteoporosis, and approach to osteoporosis and case scenarios. So this is what the DEXA, which is the dual energy X-ray absorptiometry machine, looks like. So this is our eye DEXA at Jahangir Hospital, where I work in Pune. So you really need to lie down on the machine and the arm runs over you. I know I'm telling you very, very basic things, but these are some things that people sometimes do not know. So one of the important things about a DEXA is that it is very position dependent. So your child whom you are actually scanning has to be able to lie down in a particular way without pain. So if a child has contractures, you need to think of other things. So when you talk of a DEXA, it's not like an X-ray machine or a biochemical test. So there are mainly two companies which provide DEXA scans in India, that is the Hologic and the Lunar, and the results given by the two are slightly different. Also, the energy, the rays that are used, one is called a fan beam and the other a pencil beam. So the results given by different DEXAs are different. I think if you even know this much, that is enough. So we ourselves actually moved from a Lunar DPX machine, we upgraded to an iDEXA, and we actually had to go through a cross-calibration study before we could move all our patients from long-term studies onto a new machine. So there are some more things which we need to know about osteoporosis in children and the use of DEXAs. One thing is we do not use peripheral DEXAs in children. This is a question that I'm asked many times. Another question is, if a child is on calcium supplements, it does not mean the child cannot have a DEXA. This is a complete myth, and I do not know why people encourage this. The third thing is we don't use the term osteopenia in children. And lastly, we do not see T-scores in children's DEXA reports. That is because what a T-score means is the comparison of your DEXA parameters with a healthy adult who is 21 to 30 years of age. So naturally in children, you can't see T-scores, you can only use Z-scores or Z-scores. Now, which are the parameters that are normally assessed? So mostly we do a lumbar spine. We do a lumbar spine on all the children who come to us for a DEXA for suspected osteoporosis. You know that the spine, the lumbar spine, has a lot of trabecular bone which is actually affected in both primary and secondary osteoporosis. We do femurs generally in children over 10 years of age, because one thing is because of the growth, and second thing because of the region of interest is hard to adjust at the femurs. But remember, if you do see a fracture at the femur, you're probably dealing with something serious. It's not common in children. We also look at a picture of the total body. I'm sorry, this is not a very clear picture, but we do that because we want to see how much bone the child has actually gained. So all of us are very cognizant of the fact that there are two very rapid growth spurts, apart from the one which is in the mom's womb. It is in infancy and in adolescence. But just as you gain height, you also gain bone. So if you don't gain enough bone during adolescence, it's likely that you will be more prone to osteoporosis as you grow older. That is why we always need to know the total body scan to know how much bone the child has put away. Another scan which has been introduced in recent years in the newer machines is something called a VFA, or the vertebral fracture assessment. So we actually do a VFA scan on children who come for suspected osteoporosis. The reason for this is, one thing is asymptomatic Painless vertebral fractures are seen in close to between 5 to 30% of children on glucocorticoids or with secondary osteoporosis. And these children have no complaints. Second thing is, if you look at definition of osteoporosis in children, which we will come to shortly, one vertebral compression fracture is enough for you to describe osteoporosis. You don't even have to do a DEXA scan. So coming to how do you diagnose osteoporosis in children, I don't know if any of you have had a DEXA scan done, but if your T-score is less than -2.5, then you are actually labeled as having osteoporosis. But that does not happen in children. We use the ISCD guidelines, which say that a clinically significant fracture is necessary. So without a fracture in a child, you cannot diagnose osteoporosis. So what are the clinically significant fractures? One is, of course, as we discussed, a vertebral fracture. The other is long bone fractures, up to 2 fractures, in at least 2 fractures up to 10 years of age, and 3 fractures up to 19 years of age, with a low bone density under -2 Z-scores. You know that we use -2 as a cutoff for most of the pediatric parameters. Similarly, we use it in bone. So this is how osteoporosis is actually defined in children. It is not only low bone mass. So if you have a child whose bone density is low, but who has never fractured, you can't label the child as having osteoporosis. At the most, you can say that the child has low bone mass. So why is interpretation of DEXA scan difficult in children or different in children? That is because of the fact that children grow. Because children grow, they have different growth rates, and because they have different timing and tempo of puberty, we need to remember all this when we are actually analyzing the DEXA scans. Another problem is the inherent way in which a DEXA scans. So if you ever look at a DEXA scan report, it says gram per centimeter square. So it's really not a density. So it is just an area. So what happens is, if you measure a smaller child who has a smaller area versus a bigger child who has a bigger area, the one with the bigger area is reported to have more bone density, and which is not really true. So size adjustment is required in children. This is one point. So we have actually, scientists have come up with various types of ways whereby we can convert the area to volume. So there are some calculations which we do to do that, and that is why we report the bone mineral apparent densities. So I think only if you remember that some adjustments are required for size before you can actually interpret a child's DEXA report is all that is required. Another thing is, we report bones in 3 ways. We look at them as short bones. Short bones is when children are actually short. Thin bones, that is when we call it the bone area. So the amount of bone is less for the total height. So we call that thin bones. And third is light bones. So light bones is what is really less bone mass for the total bone area. So this is really the bone density. So there are cases where children will fracture even if the bone density is normal, and this is one of the reasons, and we have seen it in many patients where the bone is very thin. So it's a thin stick versus a thick stick. So when people say that, oh, DEXA is not good enough to diagnose osteoporosis in children, you also need to know how to interpret thin bones and short bones before you can say that, you haven't found low bone mass or weak bones on a DEXA. We spoke about this. So in growing children, you need to consider puberty, because a lot of bone is put away during puberty. Around 40% of bone is put away by children and adolescents during the pubertal growth spurts. So having plenty of calcium during those years, exercising during those years is critical. It's always important, but especially during adolescence. Another thing is that you actually need to have pediatric reference data, which is age, gender, ethnicity, and height matched. So this is quite hard to do, but you do need reference data to interpret DEXA results. So we had published this in 2010, but now that we have upgraded the machine, we realized that the scans are looking completely different. So we are back to square one, and once again we've started on a new study to look at what the data looks like. One very important point is that bones get strong when the muscles pull on them. So this was actually described the first time by Professor Harold Frost way back in 1964. So basically when the muscle pulls on the bone, the osteoblasts and clasts, they get activated and the bones get stronger. So together with assessment of bone, if at all it is possible, muscles should also be assessed. So we at our center have started assessing the upper and lower limb. We use the hand dynamometer for the upper limb, and we use something called a Leonardo jumping mechanography machine to assess the muscle power of the lower limbs. So muscle is also very important. Then going to why do we do DEXA scans in children? Of course, it's for osteoporosis. So primary osteoporosis is typically largely osteogenesis imperfecta, but then you can also have conditions like idiopathic juvenile osteoporosis and forms of Ehlers-Danlos loss. So initially I used to show this slide where this was the primary bone disorder, and these are the secondary bone disorders, which means that when children have chronic disorders, just like their height is affected, their bone is also affected. So initially we used to show this slide with around 5 or 6 heads. But the number of conditions in which you find that the bones are weak is growing every day. And one of the reasons for that is that longevity has increased, cure rates have increased. That is why also the height is affected and the bone is affected in children with chronic disorders. So as you can see in chronic illnesses, in neuromuscular disorders, in endocrine disorders, in iatrogenic where you give so many drugs, and in more errors of metabolism also you do get or you can get secondary osteoporosis. So why perform DEXA scans? First is of course for osteoporosis. Most people would say, why don't you just do an X-ray? So till you lose 30% of your bone, the X-ray will not pick it up as osteoporosis. Second, as I mentioned, secondary osteoporosis is more common than you and I think. Thirdly, vertebral fractures are painless, asymptomatic, can only be picked up if you do a VFA. In many patients, very rarely, children will complain of a backache, generally they don't. And lastly, of course, follow up on bone active agents. Now, I have one specific thing to add in the secondary osteoporosis or in chronic conditions. Now, we have looked at bone density in patients with diabetes. We've recently, in fact, published this in Bone. Then we have looked at patients in growth hormone with growth hormone deficiency, in Turner syndrome, in children with thalassemia. So apart from the chronic disorder, so basically these children go out less, there is less sunlight exposure, nutrition is poorer, the disease, the treatment, lack of activity will affect the bone. But remember, in India, malnutrition and inadequately treated chronic disorders, because if you look at conditions like thalassemia or even like DMD, there are sometimes such poor patients come to us that the bones are really doing very badly in these children. So we have this additional malnutrition and inadequately treated chronic disorders to look at when we are looking at secondary osteoporosis. So finally, I get to what I am asked to talk about. So how do you actually approach osteoporosis? So initially, of course, you look at the history. If it's a high impact single fracture, you are probably just looking at an injury. If it's a low impact fracture, then if there are multiple fractures, family history, stigmata of primary bone disorder, you're possibly looking at a primary osteoporosis. You perform a workup for primary bone disorder. If it's very mild fragility, child is young, early puberty because the bones have a chance to remodel during puberty, then you probably would just monitor height, monitor bone density, and wait and watch, maybe repeat a DEXA scan yearly. If there are multiple fractures, we went through this, that if you can actually define it as osteoporosis, you treat with bone active agents, in which case you monitor with DEXA scans every 6 to 12 months. If you find that there's a fracture and there's a history of a chronic disorder and you suspect a secondary osteoporosis, obviously workup and treatment of underlying disorder is important, but remember, you also need to look at the osteoporosis and possibly treat it. Some long-term examples are cerebral palsy, thalassemias, type 1 diabetes. And Duchenne's muscular dystrophy. Remember, in Duchenne's, the muscles are very weak, and plus you treat them with steroids. So this is a double whammy, and the children have very, very bad bones, apart from, of course, other problems in Duchenne's. Otherwise, you have also conditions where, short-term, like ALL, acute leukemias, where a child is treated with chemotherapy or steroids, but once the child comes off, child may need some assistance with the osteoporosis, but then the children get back to having healthier bones. So when you're looking at measuring BMD, I'm not going to talk about the biochemistry or the genetics of it, because this is my area of expertise and this is what I've been asked to talk on. So naturally you would do a DEXA scan. Remember to look for height for age. If the child is very short or very tall, weight for age. Very light child will have undermineralized bones. Very heavy child may have more bone for that height. Look at the pubertal status. In precocious puberty, you will have higher bone mass. In delayed puberty, bones will be undermineralized. If it's an adolescent who has grown in height, but still the bones are to be mineralized, this is called as the adolescent bone gap. So you know that the commonest time that the fractures occur is in boys roughly between 10 and 14 years, and that's because of the adolescent bone gap. And of course, the disorders of puberty. If you don't have estrogen, if you have hypogonadotrophic hypogonadism, then you're going to have weak bones. So then when you do a total body scan, you look for short bones, thin bones. You look if the child has low bone density, and if you look at whether there is a primary or secondary, whether the disorder is a muscle disorder or a bone disorder. All this you can figure out on a total body scan. The femur and spine scans are normally done for the Z scores. The vertebral fracture assessment is done for a vertebral fracture, and we do run some customized scans, which I'll come to a bit later. So a few case studies. So this was a 12.5-year-old boy who came to us, and he had a backache when another child fell on him. Didn't sound like it was a big fall. An X-ray was done, and the X-ray showed a fracture. So child also had a past history of 2 fractures, one at 3 years of age, one at 9 years of age. When we looked at history, we found that mom had history of multiple fractures during childhood. Also aunt and a couple of the cousins had history of fractures. So possibly, of course, you're looking at a primary bone disorder. So we did a DEXA scan in which we found that the bone density at the spine was minus 2.03, at the femur was minus 3.9. This child had undermineralized bones, that is the BMD Z score was minus 2.9, and the bone for muscle was also very low, which means it's a primary bone disorder, and he had low bone density, he had fractures, and even if you didn't do the DEXA, the first one was a vertebral fracture. So like we saw in the guidelines, if there is a vertebral fracture, the child can actually be classified as having osteoporosis. So the child was treated as having primary osteoporosis and was treated with bone active agents and followed up. And this is what the scan looked at afterwards. It was all less than after 1 year. So all the BMDs were actually less than minus 2. So this was a primary osteoporosis, probably an OI, but we didn't manage to do any genetics on this child. In the second case, there was a 4-year-old girl who presented with a fracture of the forearm with minor trauma. So we examined her. You know that you have to enter the height and weight in the DEXA because it is adjusted for height, weight and gender. So when our DEXA technician actually measured her, she realized that she was really, really short. We have a program which immediately tells you what is the height Z score. So the child was referred to us for a DEXA scan to rule out osteoporosis. So this is a 4-year-old child with 1 fracture. So we did the DEXA scan, and we found that the spine BMD was minus 2.5, which is low bone mass. We also looked at her bones for her size, that is also minus 2.9, and for her muscle is also minus 2.5. So this child has low bone mass. So do you think she has osteoporosis? So there's only 1 fracture. So you can't really classify it as an osteoporosis. So what we did was we actually referred her to our, people like yourself, bright endocrinologists, and They did a bone age on her. Her peak GH values were really, really low. She was diagnosed to have growth hormone deficiency. She had no further fractures. So this was a case with, it's not even an osteoporosis, it was a low bone mass, but the disorder was a secondary disorder. It's not a primary bone disorder. This is a child with thalassemia who came with backache. So we did a VFA on this child, and as you can see at L2, this is called at wedging. So what we actually look at is anterior and posterior length of the vertebra, and as you can see, the anterior is much lower than the posterior. So this is a compression wedge fracture at L2. The other thing that I was talking about, children being uncontrolled. If you look at this mass, this is the liver. So this child has a massive hepatomegaly. He has thalassemia, and actually it needs a lot of expertise to read bones in these patients, and it is best left to the specialists. So this is obviously a secondary osteoporosis. There are some scans which are done, which are customized. So this is a lateral distal femur. This commonly happens in children with cerebral palsy. So you can customize scans, but it needs a lot of effort and a lot of help, especially from our foreign faculty. Now, this is an adolescent boy. I have put it here as, I know we've already spoken about secondary osteoporosis, but this child was on therapy with corticosteroids, and as you can see, this child also has a wedge fracture. Just look at this length versus this length. So after the child was weaned off steroids and treated for osteoporosis, this improved. His bone density also improved. You can actually look at these. You can also look at how the morphology of the bone has improved. So I've just put this in to say that corticosteroids can affect the bone. Yes, of course, if the disorder needs corticosteroids, you have to give them, but remember that they also work on the bones. There are some limitations of the DEXA, including it's hard to do in young babies and children because there is no reference data. Size adjustment is required. Also, if there are things like contractures, then it is hard to position the patient, and reference data is always an issue for the DEXA. So we have actually started using something called a PQCT. The PQCT gives you the trabecular bone, cortical bone, muscle, and bone geometry. The geometry is the size of the bone. So it also describes the geometry of bone. So we've started using this machine to do that. There are a couple of quick tips which I have put together. This is on what I've been doing for last so many years. So you won't find them in any textbooks anywhere. All this sounds very confusing. What are you supposed to do? So when you have a child whom you suspect with osteoporosis, use the same vendor, make sure he is using the same machine, and always insist on getting the whole report. So if you actually have pre-therapy, you have it on one machine and post on another, you will never know what is working and what is the report. So that is one very important thing. Make sure you assess height, weight, and puberty. Ask the radiologist to do a spine, total body, and a VFA, and inform him that you would like a Z-score of the spine as well as the total body, less head. So if you find that there is no vertebral fracture, if there is no easily available reference data, but you find that the machine generated Z-score, that is the Z-score which the radiologist gives you, is more than -2, and there is no vertebral fracture, possibly your patient does not have osteoporosis. Also, if you can, if you have the time, try and look at the bottom of the total body report. It gives you lots of interesting things which can tell you about short bones, low bone density, thin bones, and whether it is a bone or a muscle disorder. So to conclude, DEXA is the gold standard for measuring bone density. Make sure what kind of machine you are sending your patient to. T-scores are not used in children. Diagnosis of osteoporosis cannot be made in a child without a significant fracture. While interpreting DEXA in children, you must look at age, height, gender, and puberty. Many chronic disorders affect bone. Please remember that secondary osteoporosis is quite common. Remember the muscle bone unit. Asymptomatic painless vertebral fractures are common. And while evaluating a child with osteoporosis, it is critical to differentiate primary from secondary osteoporosis. These are my collaborators and our bone team in Pune, which is growing, And I've learned a lot of my bone from Dr. Mughal and then from Dr. Raja. So we actually have a bone unit in Pune. This is our DEXA PQCT, our body composition machine, our jumping mechanography, and we actually have this set up at two places. One is at our hospital in Jahangir, and second we have a rural outreach at Ranjangaon, which is 60 kilometers from Pune, where we are doing rural studies on children, and also I have a colleague who's working in old people with sarcopenia. Thank you.
Thank you, Dr. Khadilkar, for a beautiful talk, and I hope everybody takes a great deal of notice because it's crystal clear and you all need to listen to every sound. Are there any questions? We have a minute.
Thank you, Dr. Anuradha, for a very lucid talk. I mean, you have enumerated one of the causative agents for secondary osteoporosis is GnRH therapy, as it is very quite commonly used in precocious puberty. So, I mean, what is the exact, is there any incidence of osteoporosis, the patient which has been treated for with GnRH? Because you have enumerated one of the secondary causes of secondary osteoporosis, GnRH.
Yes, yes. So you asked, I didn't get the question. Yeah.
No,
Yeah.
you,
So
in
generally
secondary
in,
osteoporosis, you have enumerated GnRH as a causative organism. So
Yeah.
it's causative,
So,
drug.
so at least we haven't seen any. So in a child with
Literature describe any incidence of osteoporosis in
No.
treated with GnRH?
No, we haven't found.
And if
I
it
don't know
is,
if literature describes.
is the
Maybe Margaret can.
We can't understand it either.
So we reviewed this in terms of the safety of GnRH analog in
Yeah.
terms of the consensus guideline, and it is very clear that when it is used in appropriate conditions, it is very safe for the bone.
Yeah.
What probably Dr. Khadilkar is referring to is in terms of individuals who are older and who are giving GnRH analog for other indications. But from precocious puberty perspective, it is pretty safe in terms of bone.
Yeah, absolutely. I mean, we have never seen a patient with osteoporosis. I've never read any report also, so I'm assuming it's safe.
Secondly, you said your case 1 was a case of OI. Can it be of IJO? Case 1, which you have very well managed with sodium palmitate therapy, you said probably it was a case of OI.
Yeah.
Can it be IJO? Because then prognosis obviously will become better.
So we looked at it as a case of osteoporosis, given the fact that so many members in the family were affected. Also, the child had blue sclery and some deafness. So he had the primary stigmata of osteoporosis, of OI.
Okay, we have time for one more question. Okay, thank you.
Thanks a lot. Thank you.